Okay, good morning, good afternoon, and good night for some of you guys out there who live on the other side of the world. Um, my name's Beast. Today I'll be going over medical training for basic life support for medics. So, this isn't an intro course. The intro course will be on the standard BLS video. You can find it on my YouTube. Trying to think. But overall, today we'll be going over what a medic should do on scene and basically just how to stabilize and move your patient into a recovery phase. Those of you advanced medics out there, this isn't going to teach you about how to resuscitate people at lost a lot of blood. It's only going to teach you on how to resuscitate them from some and whatnot. So we're going to go ahead and go over our inventory check because it is important for medics to know what your inventory should consist of and why it's important. So personally, I always carry all three types of fluid. You should at least have 15 of each bandage on your person. Whether you carry more or not is up to you. I really don't care. You should have at least 5 nitroglycerin. You're not going to use it that much. Just keep it there just in case. You should have 5 naloxone. A lot of people are going to refer to this drug as Narcan. They're the same thing. Narcan's just a brand name. It's been around longer. This medication will reverse your opioid overdoses. Nitroglycerin, commonly referred to as NTG as an abbreviation, is used to lower blood pressure. Like I said, you can carry like 5 of these. You're not going to use it too much. Naloxone, I'd carry at least 5 because it depends on what happens in your squad. Somebody might overdose, someone might have a really high blood pressure, and it's because of drugs. You're going to have to counter that. Let's go through this. Morphine, I would only carry 5 morphine maximum because it is something that's not used commonly. It's very powerful and people are mistaking it and overdosing themselves. I would not carry a lot of these. Splints, carry 4 of them. If 1-9 can't reach you to fix that broken bone in a reasonable amount of time, go ahead and splint. It's not going to fix the fracture, but it's going to make it easier for that soldier to do something or whatever it is, whatever limb they broke. Tourniquets, you should at least have 8 on you. Mind you, carry more if you think you're going to have multiple patients, but at least 8. Surgical kit, you only need 1. It's infinite use. Just carry 1 surgical kit on you. You're going to need it to do stitches. Epinephrine, yeah, I'd carry about 10 epinephrine. This is going to come in handy for heart attacks. I shouldn't say heart attacks. I should say cardiac arrest patients, people with no pulse. And yeah, no, I'm just going to go ahead and say only use this for cardiac arrest patients or patients with no pulse because there's everything else is a more advanced level of care. Adenosine auto injectors, I'd carry about 10 to 15 of these. You're going to use them quite often. Adenosine lowers the heart rate, and that's important. It just lowers the heart rate. I'll go over the medications physiology later, just getting over inventory right now. IVs, I don't really carry 8. I have some over here, 4. You should at least have 10. Most medics carry like 20 or so. You're going to be blowing through these really fast, so always carry at least 10 or more. Now time to talk about fluids. 1,000, depending on how you've had squad experiences, you should at least have 4 bags of 1,000. I don't care what kind of fluid. I don't care if it's blood, plasma, or saline. Just carry at least 4 1,000 bags, milliliter bags. Or a 1 milliliter bag. 1 liter bag. Because it is important for patients who are critical That way you can stick one into them and just leave it be. 500s, that varies on medics. I'd always carry at least 5, maybe 6 at minimum. Everything else is up to you, medics, what you want to carry. 250s, mind you, a 250 bag is only for comfort at that point, or to speed up a process. It has no critical purpose. If you don't want to carry a 250 bag, don't worry about it. That's fine. Stick to your 500s and 1000s, but it's not a critical item. You don't need it. Personal aid kits, I recommend every person carry at least 2 or 1 to 2 for their squad, because 1-9 can only shove one of these in his bag. So when he runs out, and you have a broken bone and you really want to get packed, or 1-9 deems he's going to pack him, you're going to need this on hand. Cable ties, carry 2, 1, doesn't matter. It's a miscellaneous object. It is now a strong recommendation. I'm not allowed to say requirement, but let's just say for the purpose of tracking you guys down, for you guys to have a purple smoke grenade or a green smoke grenade. If you call for a mass cas and you say I'm out in the middle of nowhere, but my squad leader's KIA and he's back at base, I don't know where to find you. You need to give me an actual visual reference, not just, on the map. There's 2 ways to do this. 1 is through smoke grenade. 2 is through your Android. I'll talk about that later. For now, painkillers. They're kind of important. I carry at least, if you're a medic, carry 5 of them. Just in case, at least 5, in case you got to hand them off to a patient because he didn't bring painkillers for some reason. Painkillers are used to suppress pain. This is your alternative to morphine. If someone's conscious and in pain, don't give them morphine, even if they're in severe. Morphine is only to be used in a situation where you're probably going to die. You need to have stable shooting so you can increase your chances of survival. Morphine's your last ditch effort. Painkillers are going to be your long-term resolver. So you can only use 11 painkillers at a time, and by at a time I mean within a span of 10 to 15 minutes, because you will overdose if you take more than that within that time frame. Unfortunately, this is a good time to bring up Naloxone. Naloxone is a 1-to-1 ratio. That means if this patient took 5 painkillers, I'd need 5 Naloxone to counter that. This is why you guys should carry 5 at minimum, because if someone takes 11 painkillers, you're going to have to do some work to counteract that. You're going to need 11 Naloxone, and it's very frustrating. That being said, I'm going to start talking about medications and what they do. I thought one of these crates was full. Whatever. I'll just go with what I got. Alright, so you have my personal favorite, epinephrine. Epinephrine is used to increase heart rate. On this server, don't worry about the description right now, because that's real life and other servers modded. Epinephrine in our server is used to increase heart rate and blood pressure. You can only use 3 of these maximum on a patient within a span of 20 minutes. If you give any more, they will overdose and they will die, because their heart will explode, and there's nothing you can do about that. There is no fix to that. Not even Narcan can fix that. Yeah, so epinephrine will be used on cardiac arrest patients, and that's that. As a medic, you really shouldn't be using it on anything else. That's an ALS level course for using epinephrine in different terms. Morphine, a very powerful painkiller. Morphine will also lower the heart rate and the blood pressure of the patient to barely conscious. If you use 2 morphine, you will pass out. Morphine lasts for a long time. It lasts for about 15 minutes in game, 15 to 20 based on how your patient's condition is. Pitch perfect, it'll last for 15 minutes. If your patient is critical and he's still conscious somehow, it's going to last for 20 minutes because his blood level is low. Adenosine. Adenosine is even though it is a counter to epinephrine, it's not exactly a counter. Adenosine will lower your patient's heart rate by at least 10 points. So whatever you have on a heart rate, if it's 110, go ahead and subtract 10 for that. It's going to be 100 when you're done, at minimum. It may go even further, depending on the patient's blood loss. It's all about blood volume. That's that. I'm going to go down to... Yeah, I guess IVs is kind of it's an intervention. 16 gauge IVs. These are... You need an IV to push blood. You need an IV to push nitroglycerin and norepinephrine. That's what I don't have. I just reminded myself of something, so bear with me, guys. I'm just going to walk into the arsenal real quick. Snag it. Nitro. Huh. I guess this server's not updated. Okay. Well, in the main server, medics get norepinephrine. I'm not going to go over that because I don't have it, and it's kind of weird to pull out a magical medication. So our next medication right now is nitroglycerin. Nitroglycerin is a substance used to lower blood pressure. It is very potent. It only lasts for about 2 minutes, but it's extremely potent. You need to be cautious because if the blood pressure is too low, it will affect the heart rate and your patient will not come back to consciousness. Please refer to your medical chart or the medical chart that I'll have posted with the Google sheet in the description on how to utilize nitroglycerin properly. Naloxone reverses opioid overdoses. It's a 1-to-1 ratio. That's that. I hope I don't have to explain that any further than that. And I believe that covers all our medications except for painkillers and carbonate. Okay, painkillers are pretty simple. They suppress pain. You can't use more than 11 in a span of 10 minutes. Yeah, I mean, no, I can't add anything else to that. There's about like I think I've been informed that there's 10 in a box. It's 10 or 12. I can't remember, but generally speaking, there's 10 painkillers in a box. 11 will overdose. That's that. Moving on to carbonate. Carbonate is a substance you have access to. This is like the same as smelling salts. Even though it says used to restore consciousness, if your patient's at lost some blood, don't worry about that. It's absolutely worthless. You can just smack the patient and save supplies. As for actually using carbonate, there's probably not going to be a scenario in which you can, because that would require norepinephrine and nitroglycerin in its uses. That's an ALS level skill. So now let's get on to our patients, triage, and how to play medic. Oh no, Jacob's been shot by a PKM. You arrive on scene, blah blah blah, your squad calls you, you walk up. I'm going to assume you guys watched my last video, so I'm going to use shortcut keys now because I'm lazy. Okay, your patient's bleeding all over, quite literally, for some reason. You're going to start with treatment. Minor crushed tissue. And you need to know how to use proper dressings for each wound, because each dressing will have a time limit of how effective it's lasted. So if you put on a dressing, it may fall off in 5 minutes. It may fall off in 10, depending on what you use. For velocity wounds, packaging. For cuts, small cuts specifically, go ahead and use field dressing. Anything that's minor, you can slap a field dressing on it. except for velocity wounds. Velocity and puncture wounds require packaging. Large cuts, elastics. I'm going to deviate and talk about elastics real quick. Elastics will cover anything that's large, but unfortunately, they do not last very long. They are a very short lifespan. Alright, once you stop the bleeding, the next step you want to do is check pulse. It won't make sense if you're trying to stitch a dude who doesn't have a pulse. So you stop the bleeding, you check the pulse. Your patient now has a pulse. You can start your stitch. It's going to take me 46 seconds to finish this. The stitch is to ensure that no wounds open up again. And that will make sure that any wound you've bandaged will not open up. Mind you, during this time frame, if you put a crappy bandage on that wasn't proper to the wound and it opens up, your patient will now be bleeding, and on top of that, the stitch will not close that wound. So you have to bandage that again and then proceed to stitch that. With patients with a major amount of wounds on one leg or one extremity, and they are specifically, this is very specific to extremities. Extremities are arms and legs. So if his leg had like a whole list of injuries on his overview, I'd put a tourniquet on it while stitching, because if one opens up, 2 and 3 might, and so on, and it's just a list of problems about to happen, and you're stitching, so you don't know. And he's just going to lose a lot more blood. At this time, you'd establish an IVs. A standard 16 gauge IV can only be established in the arms and legs. For establishing an IV is a skill of its own. You need to find the limb with the least amount of blue on it. How to explain this? So the darker the blue the patient is, the slower the blood or the fluids are going to flow into the body. So you find the limb with that's either the closest color to white that you can find. You start an IV, and you go ahead and you drop blood into him. He's lost a lot, so as a medic, I'm going to drop a 500 in him to save my supplies. I already checked his pulse. His pulse is 92. I've started blood. At this time, I'm going to get what's called a baseline vital. So his blood pressure is 81/54. That should be 120/80 for normal patients, so you know what your goal is. You drop to 500, it's going. As you can see, it's flowing a lot faster in this arm. For those of you who are experienced medics, you know that it's flowing a lot faster in this arm than it is in this one, and there's a good reason why. Okay, congratulations, your patient is now lost some blood. But his blood pressure is a bit low. We're going to go ahead and check pulse. Heart rate of 80. And his blood pressure is now increasing. At this point in time, when your patient is at lost some blood, they can be brought back to consciousness through a slap. I don't know what's up with the numbers right now, but you would not see these numbers if your patient was at lost some blood unless he used nitroglycerin or something, or morphine. But we're going to go ahead and just say give him a slap. Your patient's now conscious. Congratulations. You have successfully resuscitated your patient. Whew, yay. I'm going to go over how to identify an overdose. If your patient happens to have like 5 morphine injected into him, so we're just going to go ahead and use this dude as an example because he's here. Most of the time, you guys are probably going to be busy doing something else. So you're going to be out here interacting with your squad leader, fighting off baddies. Your mindset is somewhere else. You're not focusing on what's going on. Your patient is probably going to be fighting too. He most likely told one person, and that's it. So, Eventually he'd pass unconscious right about now. Just give it a second. Really? Unfortunately, the training server settings and our actual server settings are different, so I do have to give him a little oomph. Get him to fall over. Huh. Okay, whatever. Bang. Your patient passed out from overdose. This will make sense in a second. This is actually the scenario you're probably going to walk up on. Some dude who got shot, he got revived, he was in severe pain, and he probably decided to use morphine. So, your patient has no blood pressure. I wonder why. Huh, I've checked this thing, which is your triage card. This tells you everything that's been done to this patient. 3 morphine 1 minute ago. Well, this is worthless. You're not going to be able to do... He's not going to come back to life with that morphine in him. You won't be able to get a heart rate. So you're going to administer 3 Naloxone. Most of the time, they're not going to have a heart rate throughout this whole thing, so I'd recommend getting someone on CPR during this process. You're not going to worry about the cut or whatever stitching he has because the opioid overdose takes priority. This is only for opioid overdose cases. You're going to do 1 round and immediately do a 2nd round because the lack of the blood flow and the time it probably took you to get there. So now you're going to check for pulse. No heart rate. At this time, you're going to say, and this goes for all cardiac arrest patients, you're going to introduce 1 epinephrine. If it's a suspected opioid overdose, I'd go ahead and call 1-9 and tell them that I have a overdose on my hands. You're going to tell him what drug if you know it, because it will depend on the treatment that we do for this patient. So 1 epinephrine and a lot of CPR. Ah, voila, your patient now has a heart rate of 124. When using epinephrine, it has a 2-minute period. Do not introduce another epinephrine. You have 2 things that tell you not to give epinephrine. Never go over 3 epinephrine auto-injectors total within a span of 10 minutes, and never use epinephrine back-to-back within 2 minutes. That's your indicators of when to and when not to use it. So I think this patient is now conscious. He's in pain. I wonder why. Probably because we took him off his high of morphine with Naloxone. So you're going to go ahead and begin to stitch this guy. You know, and now he's A-okay. And then you chastise your squad mate because he shouldn't have overdosed himself to begin with. I just went over 2 of the most common cases you're going to see in the field. That's that. You'd use painkillers for pain. You just give them like 2, and it should bring it down from 1 level of pain. There's 3 levels. That's that. I'm going to go over fluid usage for critical patients. Oh no! Jimmy here happened to eat a lot of 5.56 or 9 mils or whatever he got shot with. This is bad. This is extremely bad. This is one of those cases where you'd use quick clot. Quick clot will slow the bleeding. You only need to give 1. Bam, quick clot. Ah, I'm not going to be able to stop that very fast. Apply a tourniquet. Minor puncture wound, not critical, not critical, large. So you see large avulsion, click that, you know, whatever. I'm just gonna breeze through this because he will die if I don't do something as fast as possible. Once again, elastics are not the best bandages, so it is important to realize this so that you can say, okay, what do I do? Even though these aren't critical and they can be fixed by field dressings, I'm kind of just gonna be that guy and fix it. What's his heart rate, right? That's the next thing you want to do. Oh, no heart rate. Unfortunate. A lot of people will just go ahead and give epinephrine because they were on scene when this patient went out, like they were there within a minute. So just go ahead, give epinephrine, do CPR. As important as stitching is, once again, if the patient has no pulse, that's more important. Their heart not beating is absolutely critical to their survival. As you saw, the limb I put a tourniquet on is actually still bleeding. It's just the tourniquet has stopped the blood from leaving his body. So I'm going to ignore that for now and get his heart rate up. This will apply for any extremity when you have a critical patient. Fortunately, still no heart rate. Just give it some time. I'm going to go ahead and talk about another scenario. If you have a scenario which your patients, all your patients' limbs have been compromised, I'm not talking about, oh, one of his arms has a cut on it and the rest are blown to hell and there's nothing you can do. Patch the arm, start an IV, stitch it and go. That way you can get a flow of blood. If it's absolutely critical, like he got shot by a tank, the only thing that's not critical is his chest and his head. Call 1-9. He's going to have to come and start a fast IO because even if you bandage those wounds and stitched them and you tried to start an IV in it, you're not going to be able to because of how bad it is, or you won't be able to do anything because the amount of blood flow into the body will be super slow. So my elastic bandages just fell off while I was doing CPR. Put those back on. He's now got a heart rate of 120. This is good. So now I can do my stitch. I stopped the bleeding. I'm not entirely sure his rate right now because I didn't check his blood pressure. But I know he's got a heart rate and he's currently not bleeding. We're going to begin the stitch to prevent any bleeding in the major areas. If you have a rifleman next to you and you're not getting shot at, you're not in combat, you can go ahead and instruct a rifleman to do the CPR. That way you can focus on blood loss management and making sure that he's not going to bleed out again. So second step, he's lost a lot of blood, right? You're going to go ahead and check blood pressure. Blood pressure is really low. Oh, it should be like 72 or 60, but it's at 80. I'm not even going to bother with it. We're going to establish an IV, slap a 500. And now here comes the second part. This is fluids intake. So your first reaction is going to be to wait, but also you need to remember how to use fluids. Plasma, blood, and saline all have the same effect, but they function differently. What I mean by that is they're not, if you put a 250 bag of blood in and you add another 250 bag of blood, it's just going to merge the two and say 500. Now I added a 250 saline. Both of these are flowing at the same time. So now you have two different bags of fluids flowing into the patient, which means your patient is receiving more fluids at a faster rate. Does that make sense? So this can be interchangeable. You can use blood, plasma, and saline, and he's receiving 3 bags of blood at once. That way, 3 fluids at once without having to wait for one bag to finish. So he's going to recover much faster with that technique. Most of the time, I wouldn't use it on patients with lost a lot of blood. I'd only use it on patients that have lost a large amount or lost a fatal amount of blood, because the fatals need to get back to lost a lot in a certain amount of time or they will die. Period. That's just how it is. So you're going to check your pulse again. Make sure your pulse reading was right. It's 110. Also, if your patient has no heart rate, your heart rate will correspond with the receiving blood. The higher the heart rate, the faster they will receive blood. But generally speaking, if they have no heart rate and you've started blood, you need to do consistent CPR so that blood, that fluids will go into his body a lot faster. I'm going to be honest, I kind of screwed up here because he had a perfect right leg and I still started it on his arm. Force of habit, if you will. So let's just say this patient's blood pressure is magically, yeah, okay, now it's a more accurate number. Yeah, your patient's blood pressure is 114. He's lost some blood. You can go ahead and slap him and he'll come right back to consciousness. In this case, he did not, and I'm pretty sure it's because it's pulse. Yep, okay, yeah. So in order to make a patient come back to consciousness, whether using carbonate or reorienting your patient, aka slapping, their heart rate needs to be below 100. So if it doesn't work the first time, check the heart rate. You probably screwed up. In this downtime, while it's coming down, you can go ahead and fix all the wounds on his leg. So you can say, oh, he needs a packaging. I'm just going to run by these and fix it. I'd recommend practice for anyone on bandaging, because you're going to have to process this in like seconds and go off that. So get some practice, because it will be a lot different in the field. In this time, I'm go ahead and tell you, stitching is critical. If you have multiple patients, but you have a tourniquet on the limb, don't worry about bandaging and stitching. Go ahead and move on to that next patient if he is absolutely critical. If that patient's in the same state as this one, pick one, work on him, move to the other, work on him, and then focus on bringing them back to consciousness. That's up to you guys. Like, it's not that big a deal. That's like a whole nother art itself. I don't even want to focus on it. But I will stress this. Removing the tourniquet is kind of important. The longer it's on there, the more pain it will cause for the patient. It's not a good thing. Remove it when you can. It's not an immediate thing, but whatever. The heart rate's 101. I could wait for it to go down, but I'm lazy. I'm going to give this patient adenosine. That's going to decrease his heart rate by like 10 points, maybe 13. He's 98 now. Oh, okay. I can now proceed to slap this patient back to consciousness. He is walking wounded. If you see like all this blue, go ahead and mark him minimal. Do not say none, because he is walking wounded. That'll give 1-9 a general gist, or any other personnel to walk over him, an idea of what happened to him prior to the incident. If he's minimal while down on the ground, I have an idea of how bad it was. That is my basic lesson for medics. You've learned about overdoses, you've learned about how to check blood pressure, introduce medications, and fix your patient to the best of your ability. I would do a radio course on how to talk to 1-9, but I figured it was a bit too complicated, so I went ahead and I made a flowchart. That'll be posted 2 days prior to this video. Have a good one, gents. Hope you learned from this. ALS class will be later, and we'll go ahead and put another video on that. Have a great day, guys.